And as we begin, I would like to introduce Dr. Charmi Shah, who will be presenting today. Welcome, Dr. Shah.
Hey, it's good to be here. Thank you very much, Julie, for having us, having me. I'm Dr. Charmi Shah. I'm a clinical instructor at UCLA. I'm also a family practitioner. I've been in practice for 5 years, and I'm new to the Los Angeles area, so this is great. Prevention is a topic that is near and dear to my heart, and hopefully as we go through this presentation, you will be able to see the importance of prevention and have some insight in making sure that your health is up to date as well. So with that, I'll go ahead and get started. I don't have any disclosure, nothing to disclose. The objectives of today's presentation, the first is to identify the target population. The second is to discuss the value in primary preventative screening strategies. Third is to discuss preventative goals. Fourth, individualized and personalized medicine. And fifth, offer any resources that you can use after this presentation to check in on your healthcare and making sure you're up to date as well. So a little bit of background, the age group that I'm actually focusing on today is 50 and older. And the reason is because it's a very interesting and challenging age group. Getting older can be hard for many reasons, but individuals in this age group wear a lot of hats. So you can imagine by the time we're in our 50s, we're well established in our career or profession. We're often parents or grandparents. We also have aging parents who can have health conditions of their own. And so it can be difficult to take care of oneself. And that's often the population where that gets most neglected. The second reason is that this is a growing population and as such has increased healthcare needs. And the third is the cost to oneself when there are chronic conditions that are being managed and the cost to the medical system. What we know and why we should invest in this population and keep up with our preventative care goals is that by our sixth decade, actually by the time people are in their 60s, at least 70% would be or would have been diagnosed with at least one chronic condition. And nearly half, 50%, will have at least 2 or more chronic conditions. And so with that, what are the chronic conditions that are preventable? And we'll go through that today. So some examples, and I have listed here, are breast cancer screening, vaccinations, cervical cancer screening, blood pressure screening, and smoking cessation programs that have been very successful. What agencies are involved and where do we come up with our guidelines? So there are several different organizations that play a role in assessing screening techniques in an evidence-based fashion. And I've listed some here. The first is the USPSTF, and what that stands for is the United States Preventative Task Force Service. This is actually an independent organization that consists of volunteers who are national experts in prevention and evidence-based medicine. And they make recommendations after reviewing the data, clinical studies on clinical preventative services, such as screening tests, counseling, and the use of medications. The others that I have listed here, ACOG is the American College of Obstetricians and Gynecologists, ACS is the American Cancer Society, and of course the CDC. And so the recommendations that I will be discussing today, there is a consensus amongst these organizations and have been shown to be effective. And I talked a little bit about the USPSTF. Their grading system works kind of like this. The grades are based on evidence and literature research. A grade A, for example, if breast cancer screening was given a grade A, what that means that this service is recommended by the organization and the benefit of performing this screening method is considered to be substantial. A grade B also is a recommended service. The benefit with a grade B is moderate to substantial. Grade C is a selective offering, so this is case-based and individual recommendations, and the overall net benefit may be small. Grade D is usually a service that is recommended against, and I means that it's indeterminate or there's not sufficient evidence to advocate for the screening method. So with that, let's get started. I'm going to begin with cancer screening. So the first one I have is breast cancer screening. And the main mechanism of screening for breast cancer, of course, is mammography. There are a lot of different organizations involved in making these recommendations. The American Cancer Society and the USPSTF slightly differ in their recommendations, so I'll discuss both of them briefly. What we know about breast cancer and why breast cancer screening is important is that about 1 in 8 women, so that's about 12%, will develop invasive breast cancer over the course of her lifetime. It is actually one of the most common cancer diagnoses in women after that of skin cancer. In 2020, it's estimated that about 30% of newly diagnosed cancers in women will be breast cancer. So you can see the importance in identifying this subsect of the population. And the reason for early screening is not necessarily improved survival. Some recent data shows that yes, women are living longer that have had a diagnosis of breast cancer. The 5-year survival rate currently is about 90%, which is great. Can we attribute all of this to mammography? Yes and no. Some studies suggest that this may have to do with our treatment, more aggressive treatments. But the benefit of screening and early detection is to help decrease the morbidity tied to aggressive breast cancer, meaning the need for chemo and aggressive mastectomies. And so for that reason, mammography is quite beneficial and does a good job at detecting non-palpable breast cancer. The ACS, the American Cancer Society, recommends starting screening at 45. 40 to 44 is considered to be optional. Those in the age group 45 to 54, it's recommended to have a mammogram annually. And then 55 and older and low risk individuals could consider changing your screening to every 2 years. It is recommended to continue screening as long as one's life expectancy is it is expected to, you should continue screening as long as your life expectancy is expected to exceed 10 years. That differs from the USPSTF recommendations, which recommend a more personalized approach to screening, and they advocate every 2 years from 50 to 74. So in looking at this, you may wonder why there is a discrepancy between the two organizations. And the idea is with not only mammography, but other breast cancer, other screening modalities, is to weigh out the risks versus the benefits. And what we know is that women who are in their 40s have more or are more likely to have dense breast tissue. And as we get older, 50 and older, our breast tissues to become a little bit more fatty. So mammography does a really good job picking up on underlying malignancy in fatty breast tissue. The other reason there's a discrepancy is the highest rate of true positives comes in the group between 45 and 54. And so if one is to say, where can we get the most bang for our buck, that really is in this age group between 45 and 54. Let's see. Some people may be wondering about screening with other modalities such as MRIs and ultrasound. With MRI, the sensitivity and specificity varies. It's actually highly sensitive, so you pick up on a lot of abnormalities that may not be clinically significant. With that being said, women who are higher risk may need to be screened with MRIs. Next slide. So that takes us to the question of, well, what happens if you have dense breast tissue? What happens if you have a strong family history? And a question that I get frequently outpatient is, what is the amount of radiation that I'm being exposed to when I undergo a mammogram? So the law actually now requires reporting of breast density. So a lot of the viewers who are female may have noticed that their mammogram comments on um, moderately dense or significantly dense breast tissue. And that's not neither good nor bad. It just means that sometimes small underlying areas that could be abnormal may not get detected. And it's a good conversation to have with your primary care provider, because if you do have really dense breast tissue, instead of every 2 years, you may benefit from annual screening or using one of the other modalities. What is the actual amount of radiation that we're exposed to when we get a mammogram? And the amount of radiation is actually quite small. It's considered to be comparable to the amount of radiation we're exposed to just through the environment over the course of 7 weeks. And that background radiation comes from just minerals in the ground or cosmic radiation from space. But it's quite small in the grand scheme. And if you look at the benefit that can come from mammography, my thought is it's probably worth it. And actually, some studies have shown that individuals that do have argon or live in higher altitude cities like Denver will probably annually be exposed to more radiation than that of a mammogram. Some newer studies have addressed the role of tamoxifen use in individuals who are higher risk. And so the USPSTF has looked into that, and they actually do recommend prescribing risk-reducing medications such as tamoxifen or aromatase inhibitors to women who are at increased risk for breast cancer. And of course, low risk to any side effects that may be tied to this group of medications. And same with genetic testing. There's multiple different criteria that you have to meet in order to qualify with regards to insurance companies, unfortunately, for genetic testing. But if you are 45 or younger at the time of diagnosis, have two first degree relatives with breast cancer, or if you are male, of course, with breast cancer, you would qualify for genetic testing. Next slide. Let's move on to cervical cancer screening. So the screening method for cervical cancer is a pap smear. And of course, same thing here, the earlier the better. What we know is that we can reduce the rate of cervical cancer through population-wide screening with a pap smear at least every 3 years. And this can reduce the rate of invasive cervical cancer by 91%. So that's quite significant. What we know also is that the 5-year survival rate when caught early, meaning if the cancer is localized, is about 92%. But if it has metastasized, unfortunately, it decreases or could be as low as 13%. So another reason to advocate for screening and early detection. What is the culprit and what causes cervical cancer? The culprit is HPV. HPV stands for human papillomavirus. It is a virus, and so the good news is it can resolve, your body can get rid of it. It can also lay dormant and resurface. The virus causes cervical changes that can eventually turn into cancer. There is a vaccine for HPV. The high-risk strains 13 and 18, as well as 16 and 14, I believe, I'll have to recheck that last one, to help decrease the risk of HPV-related cervical cancer. The vaccine currently is approved for individuals up to 26. More recent studies have found that there is a continued benefit up to the age of 45, but your insurance company may not cover it. So that's something worth checking if you are a high-risk individual. Next slide. What are the cervical cancer screening recommendations? The current recommendation is to start at age 21. Cervical cancer is rare in individuals younger than 25. And what we know is that most people who are sexually active by the time they're in their 30s would have been exposed to some form of HPV. Fortunately, if we're healthy, your body, like most viruses, does a good job clearing and therefore preventing any precancerous cancerous changes. Individuals between 25 to 65 should get a PAP every 3 to 5 years. There are newer tests that screen for primary HPV alone. They're not readily used. Some clinics have them. It's still an invasive test, and unfortunately, you would still need a speculum exam in order to collect the sample. And so that's a major reason why a lot of clinics are not utilizing the HPV screening test alone. The idea is if you do not have HPV, then the risk of cervical cancer is very low. If you do have HPV or screen positive, then that would change based on what the cytology looks like, meaning the cells under the microscope would affect your screening to either every 6 months, 1 year, or 3 years. If you do have the pap smear completed and you co-test, meaning it is also sent out for HPV, then, and if it is negative, you will plan to repeat your pap smear in 5 years. If the HPV is not checked, then the pap smear should be done every 3 years. So a lot of the viewers may be wondering, I used to do my pap smears every year. I'm afraid I'm going to, miss a possible cancer diagnosis, and what led to the guidelines changing from annual to now every 3 to 5 years. And the reason is along the lines of what I just mentioned, which is we're now seeing that more than 90%, if not a majority of cervical cancer is tied to HPV. And the nice thing about HPV is that it's a very slow growing cancer, and so it takes several years for it to manifest into something a lot more invasive. So if the HPV is negative and you're someone who is low risk, then the risk of you developing cancer within a year is incredibly low. Whichever method you choose, whether it's with HPV testing or without HPV testing, you should at least get screened regularly. And you can discuss with your primary care provider which tests may be best for you. Next slide. Continuing with screening recommendations for cervical cancer, at what age do we recommend no longer screening? So for those who are 65 and older, who have had regular cervical cancer tests in the past 10 years with normal results, can stop screening for cervical cancer. There are some exceptions. So the exception would be if you have a history of serious cervical or cervical cancer or precancer, you should continue to test for at least 25 years after that diagnosis is made, even if you go past the age of 65. If you have had a total hysterectomy and you do not have a cervix, you do not need to continue screening as long as the hysterectomy was for benign reasons, meaning non-cancerous. And if you've been vaccinated against HPV, you should still continue with normal screening guidelines. The difference in terms of screening or a group of individuals that may benefit from more frequent screening are those who are immunosuppressed. So those would be examples of that would be HIV, organ transplant recipients, anyone who was exposed to DES in utero. And some studies say high or uncontrolled diabetes may also fall into this category. If you do, then your screening guidelines will vary anywhere from annually to every 3 years. Next slide. Moving on to colorectal cancer, some new studies and new recommendations this year with regards to colon cancer screening. The two main factors in colon cancer screening or colon cancer, excuse me, are age and ethnicity. So age is one of the most important risk factors for colorectal cancer. Unfortunately, the incident rates are increasing, and we're seeing that that individuals 45 and older are having higher rates. Approximately 94% of new cases are attributed to that age group. Before, we were seeing it in individuals who are older, 50 and older, but we are seeing younger people now with colon cancer. So for that reason, the American Cancer Society has recommended at least initiating the conversation of colon cancer screening at the age of 45, or at least offering it. The USPSTF agrees, and they are currently revising their recommendations. The rates of colorectal cancer in terms of ethnic groups is higher amongst Black adults. If you also have a family history of colorectal cancer, you are at increased risk, and screening for the most part should begin 10 years before the onset of diagnosis in your family member. And men are more likely to have colon cancer than women. With that being said, at this time, at least with rising cases, we are starting to offer screening to individuals 45 and older rather than 50 and older. What are the screening options? So there's two that are most commonly utilized. There are three different options. I won't discuss sigmoidoscopy today just because it's not frequently used. The two most common, one is the FIT test, which is a immunohistochemistry test. It's a stool test, and the nice thing about it is that it's not invasive and it can be done at home. You don't need bowel prep, and therefore you don't have to take a day off of work, which is convenient. It has pretty good sensitivity. It's comparable to an actual colonoscopy. What that means is that if it is negative, that it does a pretty good job ruling out colon cancer. Now, if it is positive, we cannot necessarily attribute the positive to cancer. For that reason, a positive test does have to be worked up, or should be worked up, with an actual colonoscopy. The benefit or the sensitivity of a FIT test is most effective if done annually. And it's something definitely worthwhile considering in low-risk patients, especially now during the time of a pandemic, when a lot of us are nervous or can be nervous to go into the healthcare facility. This test can be done at home, and you would just drop it off at your local lab. The alternative is a colonoscopy. And of course, the colonoscopy, it's different from the FIT test because this is direct visualization. And so therefore it has good sensitivity and specificity. The nice thing about the colonoscopy is that it can visualize any precancerous polyps that have malignant potential and can be resected. If the colonoscopy looks good and there are no polyps and otherwise clean, the recommendation is to follow up in 10 years. If there are polyps, depending on the type of polyp, you would screen between 3 and 5 years. And then the risks associated with colonoscopy are low, but you would need some form of conscious sedation or mild anesthesia. And because it's a procedure, of course, there's always the risk of possible bleed and damaged organs. That risk is very, very low, and we seldom actually see that with a colonoscopy procedure. Next slide. So moving on to lung cancer, the ACS, American Cancer Society, and the USPSTF recommend yearly lung cancer screening. A low-dose CT scan is recommended for people that are at high risk, and the people who would qualify are those age 55 to 74 in good health, currently smoke or have quit smoking in the past 15 years and have at least a 30-pack year history. And so what that is, what a 30-pack year history is, smoking 1 pack per day for 30 years or 2 packs per day for 15 years. So if that's the case, definitely discuss lung cancer screening with your primary care provider. In the interest of time, I'm going to skip the next slide and move over to cardiovascular health. So this is a big one. Cardiovascular disease prevention, heart disease and stroke are, of course, major causes of premature death in individuals younger than 65 and cause of serious disability. So the risk factors, of course, higher cholesterol, impaired fasting glucose or prediabetes or diabetes, physical inactivity, obesity, tobacco use, and alcohol. And just a quick note is that the BMI in terms of obesity for Southeast Asians is actually defined at 27.5 versus 30 for other ethnic groups. And we find that for the same BMI, Asians actually have double the risk of developing type 2 diabetes compared to their Caucasian counterparts. And another interesting fact is that for every 11 pounds gained during adulthood, Asians actually have an 84% increase in their risk of developing type 2 diabetes, so a high risk population. And I will also briefly discuss the alcohol consumption, just because some of the guidelines are changing. The current recommendation is 2 drinks for males and 1 drink for female. That seems to be changing to 1 drink per day for men and women. And a drink is actually, if it's wine, 5 fluid ounces. Beer would be 12 fluid ounces. Hypertension, so high blood pressure, the guidelines here have also changed. 130s are the new 140s and 120s are the new 130s. So what we're really aiming for is a systolic, the top number being less than 120, the bottom number being less than 80. Pre-hypertension is now considered 120 to 130. Stage 1 is 140 to 159. And the same strategies to prevent cardiovascular disease can be utilized to decrease your blood pressure. And what we know is weight loss plays a big role. So a 1-point drop in your top number, your systolic blood pressure, can be accounted for with every 2 pounds of weight loss. Let me rephrase that. So 2 pounds of weight loss can correlate to a 1 pound drop in your systolic blood pressure. Cholesterol. So cholesterol, you may benefit from statin use for primary prevention. So we're not talking about people who have had a heart attack or have had a stroke. These are people who have risk factors, but have not actually been diagnosed with coronary artery disease. So you may benefit from a statin, a lipid lowering medication, if you're aged 40 to 75, you have greater than or equal to 1 cardiovascular disease risk factor, such as diabetes, smoking, or high blood pressure, and you have a calculated 10-year risk of greater than 10%, and some journals actually have lowered that risk to 7.5%. This is a tricky one, aspirin. So aspirin, there is definitely a clear indication in the setting of secondary prevention. So of course, again, those that have underlying heart disease. There's mixed data in the setting of primary prevention, which is what we're talking about today. And what this data shows is basically the risk of bleed is higher than the potential benefit that we get from it. There is a potential benefit in people who have a high risk of colorectal cancer with the use of aspirin. So that's kind of a side note, and another thing that's worth talking about with your primary care provider if you feel you're at higher risk. However, before, almost everyone was on baby aspirin, and that no longer seems to be the case, at least for primary prevention. I'm going to quickly move on to vaccines. So of course, vaccines, influenza is given annually for the prevention of influenza. Pneumonia, there's 2 vaccines, PCV13 and PPSV23. PCV13 up to last year was being given annually at the age of 65. This is no longer the case. PCV13 actually is a great example of how successful vaccines can be. We currently mandate PCV13 immunization in all our pediatric population. And because we've done such a great job vaccinating our kids, we're not seeing it so much in our adults. And so PCV13, unless you have a risk factor such as you're immunodeficient, lymphoma, leukemia, myeloma, no spleen, etc., you don't need it. PPSV should still be given at the age of 65. Shingles is if you've had chickenpox when you were younger, you should get the shingles vaccine. The newer one is called Zostavax, and it's great. It's about 90 to 95% efficacious, and same with Tdap. That's your tetanus, diphtheria, pertussis. That's given every 10 years. Medicare coverage limitations apply with both Zostavax and Tdap. And those your insurance or Medicare will cover if you receive them at the pharmacy, but not at your primary care provider's office. Just a few more slides. Bone health, osteoporosis. Why is this important? So what we know about osteoporosis is that in this year, almost 12.5 million people older than 50 are expected to have osteoporosis. Why do we care? Unfortunately, there's a lot of limitation. Individuals who do suffer hip fractures from osteoporosis are associated with limitations in ambulation, chronic pain, disability, loss of dependence, and a decreased quality of life. Unfortunately, 21 to 30% who experience a hip fracture pass within a year of experiencing it. So the goal really with osteoporosis screening is to prevent fractures. The way that this is done is with a bone density. And if you screen and you are not osteoporotic and just osteopenic, we could do a lot of things like weight-bearing exercises and vitamin D supplementation if you're deficient to help preserve bone strength. I'm going to move on to abdominal aortic screening. Almost done. So abdominal aorta, an abdominal aorta aneurysm is defined as greater than 3 centimeters. We actually are seeing lower rates of abdominal aortic aneurysms around the world. We unfortunately don't have data with the US just because our screening rates are low. The reason this is important is in individuals who smoke, they're at higher risk for the development of an aneurysm. And usually people are asymptomatic if they do have one. Unfortunately, it's not until rupture that sometimes they get detected. So the goal is if you're a smoker or have ever smoked between the age of 65 and 75 to do a one-time screen with an ultrasound, no radiation to make sure your aorta is not enlarged. If it is, it can be monitored closely. What we worry about is the risk of rupture and the associated death with it can be as high as 81%. So we can aggressively monitor people who are at risk. And the last slide, I think almost the last slide, is depression screening. This is one that is very real and often missed and unfortunately infrequently discussed. But please know the signs. There are online PHQ-9s, which are depression screens, and GAD-7s to screen for anxiety, to screen yourself. And if you're having symptoms, reach out to your healthcare provider. So next slide, concluding remarks. I went through this pretty quickly, and there's a lot to cover in terms of prevention. But the idea is know what you're due for based on your age. Doing that can help with preventing a lot of chronic conditions. Stay up to date. A lot of these tests are low cost and often covered by your insurance. They can save lives. Discuss with your doctor which tests you would benefit most from, and use this as a tool to take charge of your health and empower yourself to be well mentally and physically. Thank you. And these are my parents who are 50 plus and hoping that they have logged in to hear about my preventative recommendations. But I'm happy to take any questions, and I have my references at the end.
Excellent. And thank you for all of the great information. There was a ton of information in there. So I really appreciate you trying to get through it all the time. I don't see any questions right now in the chat. If anyone does have any questions and you want to add them to the chat, or send a note to Julie if you want to ask them, and Julie can ask them on your behalf, we can do that as well. So we'll just wait a minute to see if there's any questions. There's a question on the abdominal aortic screening. If you could just share a bit more on that.
Yes, I'm happy to do that. So kind of, I rushed through that one, so I apologize. Abdominal aorta. So the aorta, of course, is one of the main blood vessels that delivers blood to the body. And an aneurysm is weakening of the wall. So the screening that is recommended based on the USPSTF guidelines is a one-time screen for anyone who is 65 to 75 that has ever, at any point in their life, smoked cigarettes. The reason this population is targeted is because smoking, of course, plays a role in weakening the vascular wall and can lead to aneurysm formation. So what the ultrasound does is it looks at the size of the abdominal aorta, and if it is greater than 3 centimeters, it is considered to be enlarged. Most aneurysms grow very slowly if they grow at all, but if it is there, then at least it's on the provider's radar. And you can utilize other strategies such as more aggressive blood pressure control and more frequent monitoring to make sure it is not growing at a rapid rate. This data, unfortunately, hasn't been translated to women. We are not seeing women at increased risk for abdominal aortic aneurysm, so there currently are no screening recommendations unless there is a strong family history or you have a connective tissue disorder that can increase your risk. So the recommendation is 65 to 75 with a history of smoking.
And does that history of smoking include e-cigarettes or traditional cigarettes only?
Traditional cigarettes.
Okay. Well, there's a couple more questions here. I think one, I think you're driving the presentation, Julie. So if you could back up, there's a request to show the slide with the blood pressure guidelines again. I think someone just wants to take a peek at that. And then there's a question that says the tests stop at 74. Does this mean at 80, I don't need a mammogram or a pap again with my past tests being good?
So I'll start with the pap smear. If you have had normal pap smears with no history of abnormal and you are not immunocompromised or don't have one of the qualifying immunocompromised conditions, you no longer need to continue undergoing pap smears for cervical cancer screening. Mammograms, you can continue screening. Previously, it was recommended to stop screening for breast cancer at 75. However, we are seeing people are healthier and living much longer. And for that reason, you can discuss with your physician when is the optimal time to decrease screening. It's thought that if life expectancy is not assumed to be greater than, or is assumed to be less than 10 years, that the benefit from continued mammography is less. But if you're healthy and otherwise in good shape, continued screening would be appropriate. You can span it out to every 2 years if you would like, but there's not a hard stop on mammography at 74.
Great, thanks. Is primary HPV testing the same or different than the HPV test in cervical cancer screening?
That's a good question. So primary HPV testing, they're working on a urine HPV test, and that would be great when they come out with that because that would eliminate the need for a lot of pap smears. But primary HPV testing, it's similar to, it's the same, it's screening for the same virus. It's just primary HPV testing, there's no cytology, meaning the part where we take a sample of the cervix to look at the cells under the microscope is not done. So the virus and what we're looking for is the same. The difference is in primary HPV testing, all we're looking for is HPV. HPV in a traditional pap smear is the virus in addition to the cells under the microscope. Right now we need a speculum to do both. So that's why a lot of places are not doing primary HPV testing alone, because it's the same level of discomfort for the patient. The hope is that we can come out with a urine test for primary HPV, in which case we can eliminate the speculum portion of the exam.
Excellent. Great. And then there's maybe one last question here, just in the interest of time, because I want to be respectful of everyone's day. There's some, there's sort of two camps on vaccines, and there's some hesitancy around pediatric vaccination. Do you see the same hesitancy in adults concerning vaccines, and sort of how do you navigate that conversation with patients?
Yeah, that's a great question. And I think in many ways, it's equally, if not more challenging. We have better vaccination rates with children than we do with adults. And one part of it is most of the vaccines are not mandated for our adult population. So a lot of it is in terms of really empowering and educating patients as to what the benefits of the vaccines are, and of course what the potential risks are. Oftentimes I think people don't understand why they're receiving what they're receiving, and the hope of this talk was really to help people understand why we recommend the screening test that we do and see the potential benefit. And I didn't get a chance to put all the data in the rates of pneumococcal pneumonia, and shingles, but the conversation seems to be much easier when there's meaning tied to it and benefit. And so that's kind of how I approach it with my patients, is helping to understand what the risks are, the benefits are. And I think if someone finds more benefit than potential risk, most people are willing to get vaccinated. But the key is really understanding the why. Why are we doing it in the first place? What are we aiming to prevent?
Great. And then maybe one last final question. Is it too late to get the flu shot? If you haven't had your flu shot yet, are we too late in the year for it to be meaningful?
No, absolutely not. Please still get it. Influenza is bimodal, so we see what that means is we see two peaks throughout flu season. So the first is around Thanksgiving, Christmas, and we see a second surge around February, March. So you're definitely not too late. If you haven't gotten it, you should absolutely still get it.
Wonderful. Well, thank you so much.